Hey guys, today I'm going to talk to you about mechanical ventilation and just go through some basic theory on mechanical ventilation to help you use the mechanical ventilator here at Manly Road Veterinary Hospital. Before we delve into the machine and the settings and the types of mechanical ventilation, I think it is important to understand how normal respiration works and how it will differ from your mechanical ventilation. So normal respiration involves having normal brain function, normal respiratory muscles, normal cardiovascular system, normal lungs, normal neuromuscular junction, and also we need to have a thoracic cage that's normal. Normal breathing involves negative pressure respiration, and so that means that the pressure within the thoracic cavity drops to below atmospheric pressure, and that is what draws air into the lungs. It involves two processes, ventilation and oxygenation. Now, ventilation is the removal of carbon dioxide, and it's dependent on fresh gas movement into the alveoli. And if you remember from second year physiology, that carbon dioxide is more than happy to dissociate back into a gas form if it's being pushed by something else replacing it, and that's what ventilation is. It's that expulsion of the carbon dioxide out to the out of the body. Oxygenation is movement of oxygen from your alveoli into the pulmonary capillaries, and that's dependent on the health of the alveoli. It's dependent on the surface area that is available to exchange gas, and also it's dependent on the preservation of that gas exchange barrier. You'll get respiratory failure when either ventilation or oxygenation is inadequate, and also remember with our tick paralysis patients, particularly with dogs with severe respiratory distress, they have usually already aspirated, so those patients have a failure of ventilation as well as a failure of oxygenation. So positive pressure ventilation, what is that? So that positive pressure ventilation is using positive pressure, or pressure that's got to be pushed from the outside through the ET tube, down the trachea, into the main bronchus, and then through the bronchioles and into the alveoli. And you're met with resistance at each of those points. So you need quite a bit of pressure to be able to expand the lungs to the level of the alveoli. You use positive pressure ventilation either with manual ventilation or mechanical ventilation, and manual ventilation is what we do with basic CPR, where we've got an ambu bag or a rebreathing bag from the anesthetic machine, and we squeeze that bag to inflate the lungs. That's quite labour-intensive way to ventilate, and it is ineffective for long-term ventilation. Mechanical ventilation is when a machine uses or you use the machine to force the air into the lungs, as opposed to a negative pressure mechanical ventilation is an iron lung, which we don't use these days. Now, what are our indications for ventilation? So we will need to ventilate when we have a failure of oxygenation despite oxygen supplementation. Now, failure of oxygenation is called hypoxemia. Hypoxemia is defined as having a partial pressure arterial oxygen that's less than 80 millimeters of mercury, or an SpO2 less than 95%. Severe hypoxemia is when the partial pressure drops below 60 millimeters of mercury, or your SpO2 is less than 90. These are indications for ventilation. Now, often in the early stages of a patient with respiratory difficulty, we will start with flyby oxygen or an oxygen tent, or popping them in the humidicrib with oxygen running through. We'll attempt nasal oxygen, or even put them under a general anesthetic and intubate, and put a tube down at the bifurcation of the trachea. But if the parameters don't improve, then mechanical ventilation is definitely necessary. Now, patients with a failure of oxygenation, if you remember what oxygenation involves, it's that exchange of oxygen from the alveoli into the blood. So it's going to be anything that's got primary lung disease, or a diseased alveoli, or something preventing exchange at the alveoli. So things like pneumonia, pulmonary edema, so that would be cardiogenic or non-cardiogenic, pulmonary contusions where there's blood in the alveoli, and then obviously we've got the tick paralysis dogs that have aspirated. So those are the patients that will have a failure of oxygenation. The other indication for mechanical ventilation is failure of ventilation. Hypoventilation is defined as having a partial pressure of carbon dioxide greater than 50 millimeters of mercury, and severe hyperventilation is when that partial pressure of carbon dioxide is greater than 55 to 60. Now, who are these patients? Who are our patients that have a failure of ventilation? So those are going to be ones, if you remember what ventilation is, it's that expulsion of carbon dioxide. Those are going to be the patients who can't actually mechanically breathe. So those are the patients with neuromuscular junction disease, so snake bites, myasthenia gravis, cats with tick paralysis, and a patient with a brain injury. The other indication for ventilation would be unsustainable breathing pattern, and I think this one's a really important indication for mechanical ventilation. Now, these patients will have normal blood gases, but their pattern of breathing quickly turns to fatigue. There are no set numbers to diagnose an unsustainable breathing pattern, but if you just stand next to a patient and just imitate the way that they're breathing, if you can't sustain that breathing pattern and talk normally at the same time, or if your lungs start hurting, or if you're really feeling tired, that means that this breathing pattern is not sustainable. So even with your normal blood gases, normal oxygenation, if a patient is breathing in this pattern, they are going to fatigue very quickly, and that's a very important indication for ventilation. I have mentioned this in the actual presentation. This dog has tick paralysis. Lucky, she can't move much. Her tongue's blue. This patient would likely require mechanical ventilation earlier rather than later, and I think that's one of the things that we need to be really mindful of, is that patients benefit from early mechanical ventilation. I'm going to quickly go through definitions of the settings that you'll be using on the machine. They are listed in the notes, so I'm going to go through them pretty quickly, but I'll explain some things as we go. PPV is positive pressure ventilation. FiO2 is the fraction of inspired oxygen. It's the concentration of oxygen that's delivered to the patient from the machine, and that's expressed as a percentage. Tidal volume, TV, that's the volume of air of each breath, that's measured in mils. PEEP is your peak end expiratory pressure. That's positive airway pressure that's maintained. I think it says at during exhalation, but it's at the end of exhalation. And what that does is that keeps the alveoli open at that end of expiration to prevent them from collapsing, and that's measured in centimeters of water. IE is your inspiratory to expiratory ratio. Expiration is always longer or takes longer than inspiration, and so in our patients we try and mimic normal respiration when the IE ratio is often 1 to 2, or that's your target. Inspiratory trigger. Now, a trigger is a variable that is used to trigger the machine to breathe for the patient. So depending on what you use as your trigger, in some settings trigger can be time, so the machine will breathe for a patient if the patient hasn't delivered its own breath within a certain period of time, or it can be a change in airway pressure or a gas flow that indicates to the machine that the patient has initiated a breath, and sometimes if that's your trigger, then that will trigger the machine to initiate a ventilator breath. RR obviously is respiratory rate. Your RMV or your VT is your total minute ventilation or respiratory minute volume, and that is a product of your tidal volume and your respiratory rate. PIP is peak inspiratory pressure. That is the maximum pressure that is delivered to the lungs, and that's at that height of inspiration, and that's measured in centimeters of water. So what are the types of mechanical ventilation? So once you've decided that a patient needs mechanical ventilation, you need to find out what type of breathing does the machine need to give this patient. So I've listed 4 main types. There's lots of them, and these are going to go in descending order of the support that they provide the patient. So the first one is assist control ventilation. This is where you have a minimum respiratory rate set by the operator, and each breath that's delivered is a full ventilator breath. Your ventilator breathing is either going to be pressure or volume controlled. I highly recommend that you stick with pressure control. That limits the amount of pressure being supplied to the lung, and so it's a little bit more lung protective. Now, it's called assisted control because breathing that's triggered by the ventilator is called a controlled breath, and when a patient attempts to breathe, the machine gets triggered. Those breaths that are initiated by a patient are called assisted breaths. You can set a trigger if the patient hasn't taken a breath, for a certain amount of time. So if there's, if you decide that this patient needs to take a breath within 2 minutes, then you set your trigger alarm for 2 minutes. Now, with this particular setting, you can't set a maximum respiratory rate, but you can set an alarm if the patient is cycling too frequently. So that will tell you that the patient is becoming tachypnic, and in those patients you might want to switch your type of mechanical ventilation or just adjust your trigger to make sure that the patient is breathing with a normal respiratory rate. So We would use assist control in those patients that have no respiratory drive. So those ones would be ones that have a brain injury, or snake bites or neuromuscular disease. So yeah, though, or in cases of really severe lung disease, you would use assist control ventilation. The next type of mechanical ventilation is synchronized intermittent mandatory ventilation, SIMV. So that's when the patient will take a breath as much or as little as they want to, and the machine will try to mimic normal breathing patterns and try to synchronize the mandatory breaths, which are with the patient's own efforts. So sometimes a patient will have taken a ventilator breath, so a machine will have breathed for the patient and delivered an ideal breath, and then the patient might very quickly try to breathe again, and because the machine wants to mimic normal breathing, it may not trigger a machine breath if the breath is taken so quickly after one has already been given. So some breaths are not going to trigger the machine to breathe. This one again can be set with pressure support or volume control. Definitely use pressure support in all of these patients. This type of mechanical ventilation is one with patients that have lung disease that's resolving or not as severe, and they have their own respiratory drive, and patients that don't need as much support as assist control. The next type of mechanical ventilation is CPAP. So with CPAP, basically it's just air that's flowing in through the tubing at a continuous pressure. The machine doesn't actually breathe for the patient, and so this one you would use when you're weaning off the ventilator or for patients with really mild disease, so they can actually breathe by themselves, and they don't have much lung disease, so it just reduces the work of breathing. CPAP is also decreases work on the heart, so it is useful in patients with left-sided congestive heart failure. The other type of ventilation is pressure support ventilation. That decreases the work of breathing in between ventilator mandated breaths. So it is actually difficult for a patient to breathe through the ET tube because of that resistance. So pressure support ventilation just provides a little bit of extra support during inspiration. You can use pressure support ventilation with SIMV, so that the breathing that the patient takes in between the ventilator breaths is not so difficult. Okay, so once we've decided on what type of breathing we're going to give our patient, we then need to work out what settings we will use. And the ventilator settings will be dependent on whether we have healthy lungs or really diseased lungs. So healthy lungs are ones that work normally, but the ventilation is not working. So those are your brain injuries, your snake bites, and your cats with tick paralysis, or patients with botulism. Now, healthy lungs are more compliant. They have enough surfactant, and the alveoli are not compromised, so there's atelectasis surface area for gas exchange. So in these patients you can use a lower peak because there's no danger of atelectasis. You can use higher tidal volumes because the lungs are more compliant, and you can use lower airway pressures as well. Now usually these patients with healthy lungs are set with assist control if they have no respiratory drive, or SIMV if they have some respiratory drive. So your fraction of inspired oxygen, initially everything gets set at 100%, but you need to wean down very quickly to less than 60% within 12 hours. Oxygen toxicity is a real thing. It causes alveoli damage, and so you don't want to have them on 100% oxygen for a long time. The ideal fraction of inspired oxygen once they're stable is somewhere between 21 and 40%. Tidal volume is 8 to 10 mils per kilo. Because these lungs are more compliant, you can go up to 15 mils per kilo. Respiratory rate set between 10 and 20 breaths per minute. We usually put our patients the respiratory rate at 12. Minute ventilation, so that's kept about 150 to 200 mils per kilo per minute. So your minute ventilation, you need that amount of gas or air going through the patient's lungs for adequate gas exchange. Your PIP is going to be at 10 to 15 centimeters of water, not to exceed 20. Inspiratory time is about a second, and your IE ratio is going to be 1 to 2. Inspiratory trigger, we usually set that at 1. So what you'll do is you'll just monitor to see if the patient is being triggered to breathe, or if the machine is getting triggered to breathe for the patient too often, you might need to increase your inspiratory trigger so it's not breathing too quickly. So I think with that inspiratory trigger, set that at 1 and then adjust accordingly. Your PEEP's going to be low. Remember, we're not worried about atelectasis, so it's between 0 and 4 centimeters of water. So for diseased lungs, your settings are going to be very different. Diseased lungs are not as compliant, they're much stiffer, so you need higher airway pressures to expand the alveoli. But you do have to be careful. Too high pressure can cause lung injury. So patients with diseased lungs are going to be the ones with pneumonia, acute respiratory distress syndrome, so our hit by cars that have pulmonary contusions, our tick paralysis patients, dogs particularly. You need to set a smaller tidal volume for these patients, and these patients are either going to be assist control or spontaneous intermittent mechanical ventilation, depending on their disease status. Same as before, fraction of inspired oxygen start at 100 and then very quickly drop down to less than 60 within 12 hours. Tidal volume is less, so 6 to 8 mils per kilo, and your respiratory rate is going to be higher. So you can increase, it starts at 20 to 30 breaths per minute. You can go up to 40 to 60 if you need to increase the oxygenation. Minute ventilation, remember we're keeping that at a constant of 150 to 200 mils per kilo per minute. So because we've dropped our tidal volume, we have to increase our respiratory rate to get enough air going through the lungs. PIP is 15 to 20 centimeters. Usually you don't exceed 20, but you can slowly go up to 30 if you need to increase your oxygenation and expand the lungs. Again, inspiratory time will be 1 second, but because we've increased our respiratory rate, your IE ratio may be closer to 1 to 1 or 1 to 2 than 1 to 2. Inspiratory trigger, again, keep it at about 1, but you can adjust, and it's normally between 0.5 and 2 liters per minute flow rate. Now remember, your PEEP's going to be higher, so 4 to 8 centimeters of water to start off with. That's to help to stop these alveoli from collapsing. You can even increase up to 20 centimeters of water, but you have to do this slowly. You can't start at a PEEP of 8 and then the next time adjust it straight up to 20. You have to go slowly because you need to slowly expand the alveoli or slowly expand the pressure that you're applying to the alveoli. So make sure that if you are increasing your PEEP that you're doing it very gradually. Alarms, I think Paula probably touched on this a little bit more, so I'm just going to flip through this really quickly. High pressure is 10 centimeters above PEEP, low pressure 5 to 10 below PEEP, and low PEEP is 2 to 3 centimeters below your set PEEP. Okay, so your target values on your patient. So these are really important. These tell you that you are adequately mechanically ventilating the patient. Now, traditionally, our goals are to have normal values with least aggressive ventilator settings as possible. And that's still true. What they have found is that trying to be really strict with keeping normal levels can lead to complications, because we increase the oxygen level and we get oxygen toxicity. We increase pressures so that we can get good oxygenation levels, and we cause damage then to the lungs with that extra pressure. We add extra volume trying to expand the lungs, and it will get trauma from that. And in its worst form, we can actually cause acute respiratory distress syndrome in trying to get these tight normal values. So yes, we do need to keep these patients at a least aggressive ventilator settings as possible, but we've kind of adjusted our definitions of normal for a ventilated patient. So realistic targets would be having a partial pressure of carbon dioxide above 50 is okay. Your end tidal carbon dioxide between 50 and 55, remembering that your end tidal carbon dioxide is about 3 to 5 above what's in the blood, and your partial pressure of oxygen, keeping that at 55 to 80, which is a SpO2 of 90 to 95%. Now those levels are absolutely fine on a ventilated patient as long as the patient doesn't become acidotic, and you can even get a little bit below normal. So normal pH would be 7.35, but as long as the pH doesn't go below 7.2, this patient is considered at target levels. Now this process that I've just described is known as permissive hypercapnia, and that has been shown to reduce the incidence of acute respiratory distress syndrome, and also decreases the chances of death for a ventilated patient. So it's quite protective. Now, what do you do if you're not reaching your target values? You will increase your peak inspiratory pressure and increase your respiratory rate. Then after about 2 to 3 minutes, you're going to assess, is that good enough? If it's not, you're going to increase your inspiratory time. Maybe it's just taking a bit longer for the lungs to expand, but you also need to make sure you're giving your patient enough time to exhale. Otherwise, the lung will continue to be too expanded, which is called intrinsic PEEP, and that's going to make it more difficult to get rid of carbon dioxide. And you're going to increase your PEEP up to 15 centimeters of water if needed, and then reassess. Is that good enough? If it's not, then go up to increasing your fraction of inspired oxygen. You can go up to a maximum of 100% for short periods of time, or just keeping it at 60 for a couple of hours or so. And then you can also increase your PEEP to that maximum of 20. What are the complications of ventilator therapy? So cardiovascular compromise, because we are increasing pressure within that thorax, it can compress veins and also smaller arteries, and that can lead to arrhythmias from myocardial ischemia. Make sure that our patients are attached to an ECG, either a continuous monitoring one or just hooking up to something that will print out every now and again, so you can check to see if the patient's heart is pumping with a good rhythm. ventilator-induced lung injury. So I have kind of touched on that. There's a lot of literature about ventilator-induced lung injury. In its worst form, it will lead to acute respiratory distress syndrome. So it's basically when we're trying to expand these lungs, particularly diseased lungs that are not compliant, and we cause more damage, shearing injuries, and that can actually cause fluid to build up in the lungs, and that's what leads to acute respiratory distress syndrome. We avoid ventilator-induced lung injuries by using permissive hypercapnia and using your lower tidal volumes and your low pressure, the lowest pressure that you can, and increasing your respiratory rate, and just be really careful with your PEEP to prevent atelectasis, but also not to keep those lungs so expanded that they're going to get damaged. Ventilator-induced pneumonia, this is a real thing. When we put our patients on a ventilator, obviously we've got to put them under anaesthetic, but we also are bypassing every single defense mechanism that the respiratory system has for bacterial contamination. So we've got a tube that goes straight into the endotracheal or into the trachea. These patients can't cough, they have reduced ciliary action, and we're kind of touching around their mouth without, sometimes without gloves, and we're sticking probes, around the trachea. So these patients do need antibiotics, and I think particularly at Manly Road, the main indication for mechanical ventilation is tick paralysis, and it's mainly dogs that we ventilate, and these dogs we know have aspiration pneumonia. So these ones we definitely need to start on antibiotics. I've listed a couple of broad spectrum antibiotics that we could use, and the recommendation is to do a bronchoalveolar lavage before adding anything more than these broad spectrum antibiotics. You also need to make sure that you're using excellent hygiene and nursing care, so make sure you use gloves where possible, make sure that you're keeping the oral area moist and clean with antiseptic, and making sure that when things like using sterile ET tubes and suctioning with sterile tubes when we're going into the endotracheal tube to suction. Another known complication of ventilator therapy is pneumothorax. It's a dangerous one. If you notice your patient is bucking the ventilator, so not able to, or not breathing with the ventilator, and if you're noticing that the chest is not moving very well, and you've got a sudden onset of really high carbon dioxide and markedly reduced oxygenation, if you pop your stethoscope and you can't hear any lung sounds at the top dorsally, that's quite classic for a pneumothorax. Once a pneumothorax develops, you need to be very, very quick with your treatment of a thoracocentesis, and you probably need to have a continuous drain in place because we are still ventilating this patient, so we are still pushing air through the ET tube into the lungs, and so some of that's going to still drain out. Once you've diagnosed a pneumothorax, you need to really drop down your tidal volume and your pressure control and increase your respiratory rate. Obviously you're still draining with a thoracocentesis, so hopefully you'll be able to get some lung expansion. If a pneumothorax is not treated quickly, it can lead to a tension pneumothorax, and that would be when there's so much pressure within the thoracic cavity that it actually compresses your major blood vessels, and that will lead to reduced cardiac filling and a drop in blood pressure and death pretty quickly. So just to summarize, you need to put a patient on a ventilator. Ask yourself, can this patient initiate a breath? And if it can't, you're going to use assist control, because that's the most support that the patient needs. If yes, it can initiate a breath, ask yourself, does my patient have really severe lung disease? If it doesn't have any lung disease, use your SIMV with healthy lung settings. If you've got mild lung disease, then use SIMV with diseased lung settings. If you've got really severe lung disease, then use your assist control and diseased lung settings. Always use pressure controlled breathing, so make sure your breaths are pressure controlled, not volume controlled, because that will allow for less lung injury. And use your CPAP for weaning off the machine. And that's it. If you guys have any questions, I'm happy for you to email or just come and grab me when you see me. If something doesn't make sense or you're not sure about something, then please come and contact me either via email, text, or just when you see me running around Manly Road. Okay, thank you very much.